Like, share, and subscribe here on Oncology Tube to get notifications when similar videos are available.
So the first reminder is that the Barcelona Clinic liver cancer staging system algorithm continues to be a very useful one for the management of hepatocellular carcinoma across all stages of the disease. But two important developments have occurred over the past 5 years that changed this algorithm, and I'm going to highlight these two. One is we have a lot more systemic therapy options. So we now have two IO combinations that are the standard first-line treatment for advanced HCC, and I'm going to review them shortly. Second-line therapy and beyond is largely empiric. We basically shifted all the TKIs that we had into second and third line without much data post-IO. The other big development is because of the improvement in systemic therapy, the intermediate stage HCC, which is BCLCB, these are patients with liver-limited disease, no extrahepatic mets, no vascular invasion. That's now been broken down into 3 subcategories. But I want to draw your attention to this category. These are the patients with extensive bilobar liver involvement or diffuse infiltrative disease. We used to give these patients liver-directed therapy with very poor outcomes. Now the algorithm has shifted those patients to receive systemic therapy up front rather than do liver-directed therapy first. So these are the two most recent changes in this algorithm that are important to note. There's also now a place for radioembolization for single lesions less than 8 centimeters, kind of doing a radiation segmentectomy as an option for early stage HCC as well. This is the historical trajectory. We started with sorafenib, then lenvatinib showing non-inferiority then lenvatinib data. So these were the two TKIs showing survival benefit in first-line HCC. The Nivo study failed to show superiority to sorafenib. Then came the IO combinations, and now we're talking about median overall survivals between 16 and 19 months. For first-line HCC in patients with Child-Pugh-A cirrhosis, of course. So the IMbrave 150 study is the one that established atezo-bev as the first-line standard, and this was compared to sorafenib. A reminder, this study required an endoscopy for all patients within 6 months prior to starting treatment. This is given the risk of bleeding with bevacizumab. And the study had co-primary endpoints of PFS and OS, and it met both. And this is the survival data, 19 versus 13 months with sorafenib. So this became the standard of care until the Himalaya trial read out, which is another IO combination, but this is combining anti-PD-L1 with anti-CTLA-4, durva, and tremi. What's interesting about this regimen that was utilized here, what we know as this, referred to as the STRIDE regimen, is that it gave only one priming dose of CTLA-4, a high priming dose. And that was sufficient to change the tumor microenvironment. That's the hypothesis, and continue with durvalumab alone. So this study had two comparisons. It compared tremi-durva to sorafenib and durva to sorafenib. There was no direct comparison of the combination to durva alone. And this regimen was closed early because this was the preferred regimen from the phase 2 study. Now, this study excluded macrovascular invasion, to no main portal vein invasion, and it did not require an endoscopy prior to enrollment. Again, the combination of tremi-durva was superior to sorafenib, showing a survival benefit. And what was unique about the study is the long follow-up with the 36-month OS of 31% with the combo versus 20% with sorafenib. So quite striking for advanced HCC. We had not seen data like this previously. The medians here are 16 versus almost 14 months. Of course, there's always this temptation to do cross-study comparison with atezo-bev, but where these were quite different trials. So this was, again, a positive study on its own. And the other endpoint of the study was comparing durva to sorafenib, and this showed that durva was non-inferior to sorafenib. So this was a non-inferiority comparison. with a median OS of again, 16.6 months for Durva and almost 14 months with sorafenib. And again, see the 36-month follow-up here, quite striking. This is now the update from ESMO GI 2023, where we have 48-month overall survival data with Tremi-Durva at 25% versus 15% with sorafenib alone. So great, now we have two IO regimens that are combinations in first-line HCC that represent a standard of care. You could use either one. These are, I'm putting them here side by side just to point out two differences that are important. There is a higher response rate with atezo-bev and a higher PFS. So this may be a preferred regimen when you have somebody who's symptomatic that needs a response. Otherwise, they both have an OS benefit and both have prolonged duration of response. The risk of bleeding is slightly higher with atezo-bev, but these were mostly low-grade bleeding events. And of course, the usage of bev requires an endoscopy prior compared to this regimen that doesn't. Of course, this is a bit of an unfair comparison because the STRIDE regimen did not allow main portal vein thrombosis, and these are the patients that mostly bleed. So it's important to keep that in mind. But nonetheless, we do have two options for first-line HCC. Now, is there still a role for single-agent anti-PD-1 therapy? Yes, that's the short answer. That's mostly for patients who are poor candidates for combination due to performance status, maybe CHALP-UB score, etc. And that is really very consistent data with single-agent PD-1. The Checkmate 459, it was a superiority design with nivolumab versus sorafenib, 16 months with nivolumab. With Himalaya, it was non-inferiority, Durva versus sorafenib, also 16 months, and Rationale with tislelizumab versus sorafenib, 16 months. So very consistent data with single-agent PD-1, great option when you can't use the combination. So this is my algorithm today. How do I approach patients? Again, the two IO combinations are really the standard first-line treatment. STRIDE without bevacizumab is preferred when you have high bleeding risk and you cannot get an endoscopy. When you have IO contraindications, you go with the TKIs. And then otherwise, single-agent PD-1 is an option for patients who are not candidate for combination. When I take the gloves off and don't think so academically, I think when patients have high symptomatic tumor burden, I prefer atezo-bev given the higher response rate. Otherwise, STRIDE is definitely a great option. And the single-agent PD-1 have really the lowest AE risk in multiple studies. And of course, the TKIs still have the convenience of oral therapy. What about early-stage HCC? So this is important. This is the first time we have adjuvant data for this disease after a long time of failures. So this is the I Am Brave 050 study, which was presented at AACR this year and updated at ASCO a bit with PRO. This took patients who are at high risk of recurrence after resection from HCC. Of course, they were all CHALP-UA, but let's look at the definition of high risk. It's down here, it's buried here. But these are tumors that are greater than 5 centimeters or more than 3 tumors, patients who have microvascular invasion on the resection specimen, or who have visible macrovascular invasion on CT, but it's localized. It's VP1 or VP2, so it's right next to the tumor. Or poorly differentiated with grade 3 and 4 pathology. So that was the definition of high risk. This was not for all comers. So patients were resected and randomized 1-to-1 to active surveillance, which is the standard, versus atezo-bev for a year, for 12 months. And the primary endpoint was recurrence-free survival. RFS is primary endpoint, OS is a secondary endpoint, and there was an interim analysis that was planned, which was what was reported at AACR. Now, the study allowed crossover. It's an important factor to remember that patients who recurred were allowed to cross over and get atezo-bev, so keep that in mind. The other important factor is that it allowed adjuvant taste. You're going to say, where did that come from? Well, that's because the study allowed China participation, and in China, adjuvant taste is considered standard. They do taste to the bed of the resection. So they allowed one cycle of taste adjuvantly, which was only done in China. And, sorry, here are the baseline characteristics. These were mostly hepatitis B patients, and 80% were Asian. So it was really mostly an Asia study, but there's definitely participation from the West. But I want to draw your attention to a few things here. So the majority, 91%, had one tumor. And then only 11% had adjuvant taste. When you look at tumor size, 52% had tumors that are greater than 5 centimeters. 61% had microvascular invasion on the resection specimen. And 42% had poor tumor differentiation. Now, the study also allowed patients who received ablation, which were a minority in the study, only 12%. And here you see the breakdown. The majority had a single tumor with a median size of 2.5 centimeters. So it was mostly a resection study. And here's the primary endpoint, and you see the median recurrence-free survival has not been reached, but you see a hazard ratio favoring the atezo-bev arm with a 28% reduction in the risk of recurrence. And you see the 12-month time point of recurrence-free survival with 78 versus 65%. Notice this is a short follow-up, median of 17 months only. But the reason this was, well, this met its primary endpoint. You know, at interim analysis, it's a positive RFS. We don't have OS data yet. It's very immature. And the curves here come together, which is probably mostly because of censoring and because of the short follow-up. So a lot of us are wanting to see longer follow-up, but nonetheless, this is a positive trial per statistical definition, okay? And certainly for high-risk patients, this is now a reasonable option to offer post-resection. The OS is going to be murky because of the crossover, by the way. So 80% of the patients who had a recurrence crossed over and received atezo-bev. As far as tolerability, no surprises from what we know about atezo-bev. So it was not more toxic in the adjuvant setting. And I think I'm going to switch gears now to biliary cancers in the time that I have left. So switching now to cholangiocarcinoma. First, let me talk about advanced disease first-line treatment. As you know, GemCis with durvalumab became the standard when it was compared to GemCis alone in the TOPAZ trial, which showed a survival benefit. Of note, this trial only gave the combination for 8 cycles or 6 months. Then patients were continued on durvalumab alone or placebo alone. And this trial was positive with a median OS of 13 months versus 11.3 months. But what I'm showing you here is updated survival from ESMO 2022 going now out to 24 months. We had seen the 18-month data previously. And you see the difference is continuing, 24% OS at 24 months with durva plus chemo and 12% with chemo alone. Now we have a second set of data with GemCis pembrolizumab showing the same thing. And this was presented this year in 2023 by Dr. Katie Kelly. Similar design, first-line advanced cholangio, all comers, all sites of disease. One of the differences is cisplatin was dropped after 8 cycles, but patient continued of gemcitabine pembro or gemcitabine placebo. So only the cisplatin was dropped. Well, similar outcome here. This is a positive trial with a median OS of almost 13 months compared to 11 with GemCis placebo, hazard ratio of 0.83. So eerily similar and just really gives credence to the data. 24-month OS rates of 25 versus 18% as well. I'm showing you here the subgroup analyses, which are usually only for hypothesis generation. But it's important to highlight here that there's a trend that the benefit seems to be most accentuated in the patients with intrahepatic cholangio, which were the majority of the patients in both studies. So keep that in mind. But also the study showed that the benefit was similar whether patients were recruited in Asia or non-Asian, and the same with the Topaz trial. PD-1 didn't matter, which is not a surprise. As far as tolerability, no surprises. These are the immune-mediated adverse events. You see only 7% grade 3 and 4, and 22% any grade. 9% requirement for steroids, so certainly manageable regimen. Now I'm going to end with reminding you that post-first-line therapy, cholangiocarcinoma is the new lung cancer in the GI space. It now has been broken into multiple subtypes, and there are different frequencies of different mutations depending on the location of the disease. So with intrahepatic cholangio, we tend to see more FGFR2 fusions, IDH1 mutations. With gallbladder and extrahepatic, we see more HER2 and EGFR alterations, as well as RAS and RAF. So I don't have time to go through all of this. What I created for all of you here is a table that shows the actionable alterations with actual clinical trial data that's been reported, with all the references below. In green are the agents that have either accelerated approval or full approval also. The others, we just have clinical trial data. But message here, patients with cholangio should be profiled early with first-line therapy, and so we can plan out their subsequent lines of therapy, second and third line. Certainly great data with FGFR2, IDH1, HER2, and BRAF. And there are actually novel agents being tested in this space, like second-generation FGFR2, like the Relay compound, second-generation IDH, the Loxo compound, and many more HER2 compounds coming on board as well. So, in conclusion, in regards to biliary cancers, anti-PD-1 therapy is now standard for first-line advanced biliary cancers with 2 positive phase 3 trials. Biliary tract cancers are the new lung cancer in the GI space, as I said. Tumor profiling is critical early on. Targeted therapies are preferred for patients who have actionable mutations in second line and beyond. For those without actionable alterations, there's still a big unmet need. We only have data with FOLFOX or 5-FU Onivyde, which have really limited efficacy in this space. Thanks for your attention.
Like, share, and subscribe here on Oncology Tube to get notifications when similar videos are available.